Good morning. I love that backdrop. That let me just tell you, that's all of the things. Look, I'm feeling some kind of way. Look, even though my stuff back, I'm feeling some kind of way. I feel like I need a backdrop like that. That is the bomb. I love it. I love it. I love it. Okay, wait a minute. Let me stop this banner. I think because we here. We here. Okay, okay. All right. Well, welcome everybody. Welcome, welcome, welcome to I'm excited. I'm excited. I love when we have guests. It's so much fun. I love bringing what they say, bring the virgins to the mic. I love it. I love it. It's so much fun. Well, welcome everybody to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurship, uh, just everything, all the things. There's a laundry list. If you go back and look at some of our previous episodes, you know that when it goes down here at the Saturday morning tea. I am Clarice Warner. I am the Grow with the Pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key, located here in gloomy, normally beautiful, but gloomy looking today, Cincinnati, Ohio. um, Before I introduce my co-host, let me ask you, do you know what it takes to be a certified marketable medical coder? Do you really? If not, let me share with you information on a free, yes, I said free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
All right. So if you are in Clubhouse, and again, welcome to those joining us in Clubhouse, feel free to click the link. If you are, bless you, if you are interested in getting more information about, do you need some tea, sir? If you are interested in getting more information about the 5 steps to become a certified marketable medical coder. For those joining via YouTube, Facebook, and LinkedIn, check out the video description or check for the link in the video description. I know it's a lot of information there. I promise you the link is there. Just scroll down. Just scroll. You'll find it. So joining me today is my co-host, Mr. Jesse, the registered trademark. I'm so proud of that. I love that. The coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been a nurse for quite a long time. I switched to HIM in 2014, and during the pandemic in 2020, I created a company called The Coding Nurse, where I help other nurses and people with clinical background experience transition into the wonderful world of HIM.
All right. And how is that going for you?
So far, so good.
Okay. All right. So before we jump in today, let me remind you that if you are on Clubhouse and want to join in and add to the conversation, please raise your hand. We'll be monitoring the room. Don't be shy. Your opinion matters here and is welcomed here. All opinions matter. And for my Facebook, YouTube, and LinkedIn friends, you all know what to do. You do it well every week. You use the chat feature. If you have a question, however, I just ask that you type a Q in front of it so we know it's an actual question and we're not just engaging in back and forth conversation. We don't want to miss any questions. We want to make sure we answer those. So let's get into it. First of all, how's your week? What's going on? Everything's good?
My week has been fine. Work was it was kind of challenging this week. I don't want to say I don't know why, because you know why. But I got through it.
Okay. Cool. She said it's a little hard to hear you in the comments.
Really?
Yeah, let me see. I don't know. It might be me. Hold on. I might need to bring you up some. Okay. Try now.
Okay. How
Okay.
about now?
Yeah, you're good.
All right.
You're good, good. Okay. So, yes, you said yes.
Okay.
All right. So, let's get into what's happening today. But before I jump into that, let's start with a church announcement. I love the banners in a church announcement. I do. Church announcements, church announcements. Okay. So, for those of you who live in Ohio and are a part of OHEMA, we had our annual meeting and trade show this past week, and it was fabulous. It was our first time back in person. So, they didn't have a virtual option this year. Everything was in person. We were nervous about that. The numbers were a little lower, especially for we have one day that's dedicated to coding. And so, a lot of people are, of course, working remote and at home. So they don't necessarily get out much. So our numbers were lower in that respect, but we had a wonderful, wonderful time. I got my gavel, so I become official as the president of the organization in July 1st. And yeah, it was all the things. Thank you. I have a little clip. I had to, you had to get those social receipts. So I had somebody, because I was at the podium and I had to give a speech and the whole shebang. I was like, anybody, get your phones out. I need some social receipts. I can't do it up here. So that was fun. So one thing I just wanted to mention, really, really good information, really great speakers. I have a lot of information and content that I'll be bringing to you from the conference. So only thing was, I was a little sad that this was also OHEMA's Heal Day and advocacy. And y'all know I'm all about the advocacy for the profession. So I was unable to go to that. So I was in my feelings a little bit. And I tried to make mountains happen. Like, well, if I go for this day and then fly back here and then fly back there. And I was like, girl, you're going to drive yourself crazy and stress yourself out. Stop. So I just decided no, but I'll still get to DC for a couple occasions because I'll be graduating this year. And so I'll get to DC for that. Okay. But the other church announcement is, hey, Shay, good morning. The other church announcement is in Ohio. We had two local associations, the Greater Cincinnati Health Information Management Association and the Dayton Health Information Management Association, or Miami Valley. I'm sorry, that's what they were called. But it's mostly, I call it Dayton, but it's mostly Miami Valley. Well, they merged due to lack of volunteers in one area versus the other, and all of the things. And so they got the approval to merge. And so now they are the Southwest Ohio OHEMA Association. So you should be hearing, if you're in that area, you should be getting emails and hearing more information about how to join the Southwest Ohio. I don't know how they say it. SWOHEMA. Maybe it's SWOHEMA. SWOHEMA. So just that small church announcement for the good of the association. Mr. Jesse, did you have any church announcements? I didn't ask you last week. Did you have any church announcements that you want to bring? Oh, well, we did verify that Utah did get the full nursing authority, full practice authority for nurse practitioners. So we did verify that. So that one is a go. You're muted and I don't hear you at all. And I don't know why. Okay, there you go.
I don't have any announcements, but I did share with you via LinkedIn because I realized, I'm like, oh, why is everybody now talking about interview skills? And I just realized there's a gazillion people graduating college. So they're in the process of interviewing. So that was an interesting article that I shared. And it was really just piggybacking what we had just talked about last week.
Just talked about, see, I think they be listening to us. I don't care what you say. I know it's some graduates coming out. I know, but somebody is listening to us and the content that we bring. They act like they don't, but they listening, and we welcome you. And come on in and join us. Don't be shy. Don't be shy. It's all love. It's family up here in this room. Okay. So today. So for those who are just joining us today, we have a special guest. So joining us today, wait, let me bring her to there we go. So joining us today, we have Ms. Molly Staley, the healthcare business consultant. And let me apologize to everybody. I missed the business part of her name. I just had the healthcare consultant because I knew that's what she did, but she's the healthcare business consultant. You better, let me put respect on everybody's name. Y'all know I don't play that. So Molly, please introduce yourself and tell the folks all about you.
Thank you, Clarice. Also, hello everyone. My name is Molly. I am a healthcare business consultant. I've been in the field for about 15 years, and like Jesse as well, back in 2020 when the pandemic first hit, I started my own business, my consulting business. So what it entails is I help providers with their revenue and also their billing, and then I do consulting with, their medical staff. They're like their front desk staff and their billers and so forth. So yeah, and I love it because I love helping people. So
all right, good. So I told Mr. Jesse, I'm gonna remind you again, and I also told Molly that StreamYard has this new feature that you can push this to. Okay, so y'all, I don't know what it looks like back there because I haven't been a guest on anybody's show yet. So if y'all get y'all shows and y'all want me to be a guest, y'all let me know. So I can't play with it. So until somebody tells me what it looks like, then I can share that information. Okay, let's see. Good morning. Let's see, we got some shout outs. Good morning to the crafty coder. Yes, ma'am, we have our finger is on the pulse and somebody is listening. And then she also says, welcome, Molly. So welcome. So today, Molly is going to give us the 411 about physicians charging for emails. And when I tell you, I first saw the information, and when I went out to do some research, stuff is all over the place. And I'm like, well, wait a minute. And I know I did a video a few weeks back just talking about the qualified non-physician healthcare provider providing for that service. But then the whole thing and the folks in the chats and comments, and it just exploded. And I'm in my feelings about a couple of things. So, but I will let you take control and walk us through your presentation on the physicians charging for emails.
thank you, Clarice. So how I was able to get the information, I get alerts on my phone. So it was actually on the news where they did a brief segment on providers could possibly start charging for email. So I did a little bit of research, and then I pulled up an article, and it's not exactly mandated yet as of yet. It's at the provider or doctor's discretion if they want to charge or not. But they do have the codes in place for it. And then there are some stipulations. You can't charge with 2 or 3 times for the email. You have to be within that 7-day span. And then for the RXs, which is the prescriptions like refills and scheduling appointments, they're not supposed to charge for that. But for if you want to change your medication in the email, if you have a new medical issue, and then also too, if you have a long-term health condition, those are the factors when they can charge you for the email, which I found, very interesting, because I did a rule on it as well. And then for Medicare, because Medicare, they're sticklers for a lot of things. You have to have a secondary insurance. If you don't have a secondary insurance, Medicare could charge, a small copay. But if you do have a secondary insurance along with the Medicare, like Medicaid or a Blue Cross, they're not supposed to be charging you. And I did like a little poll study because I wanted to just see, if any providers, not just in my state, but like in any other surrounding cities or states. So I'm in an AAPC group, and I did pose that question, and I did get a response that it was someone that lives in Cleveland, and the Cleveland Clinic, actually, she said the providers that she works for, they're charging for emails. And I also interviewed a therapist that's local in my city, and she said she doesn't charge, but her colleagues, they charge for emails. So it's kind of a slippery slope. I think some providers aren't aware, excuse me, of, this type of thing right now, but some are aware. And when I did my room, I personally said to me, it's a money grab because during the pandemic, a lot of people stopped going like to the doctor in-house. They started just doing it online, because of the pandemic and everything, and because of COVID. So, and I'm guessing like they're losing kind of revenue in their business. So they feel like, okay, let me charge for this email. And maybe that'll help, with their revenue. But to me, I think it's a money grab. Personally, I do have a provider, a PCP, and she doesn't charge me. I even text her. That's how good of a relationship I have with my PCP, and she doesn't charge me at all. So I found it very interesting. But not all providers or doctors are starting it, but some are starting to charge.
Yeah, well, I did similar research, and yeah, there was a whole study done about the providers charging. And first the article that I saw referenced the study. So of course, me being me, I had to read article, then look at the study and see the results of the study. But the one thing that was very, very interesting to me about the information was they kept talking about this administrative burden with documentation. And y'all know that just gets me every single time. I do not, that it's astounding to me why a portion of someone's job that they signed up to do is a burden. Documentation is the end all be all of everything. And yeah, so that's one soapbox that I won't jump on today, but that was part of the conversation that was actually discussed in this article. But even with billing for these services, and I'll say the CPT codes for the physicians billing, you have 99421 through 99423. And Medicare or CMS proposed reimbursement for those who are doing it's like $15 for the first, because these are time-based codes. There's a minimum of 5 minutes that must 5 minutes of, I think, medical decision making, or wait a minute, let me find the actual code. See, I should have had all of that together. So you know the exact language for the code. So it's an online 99421 is an online digital evaluation and management service for an established patient for up to 7 days, cumulative time during the 7 days, 5 to 10 minutes. And then 99422 is for 11 to 20 minutes. And the charge for that is $31, or the reimbursement for that is $31. And 99423 is for 21 or more minutes, and the reimbursement for that is $50. Again, that's just Medicare's reimbursement, but they have documentation requirements for this as well. So even though you are charging for it, you still have to document, what you put into that 5 minutes that you to actually charge for that service. And so I'm like, on one hand, oh my God, we're doing too much. We can't document all the things. But on the other hand, you're trying to nickel and dime all your patients for every single thing. And it says one of the article participants, his name is AJ Holmgren, and he says billable under the law are messages that require at least 5 minutes of clinician time. So your physician has to spend a certain amount of time actively addressing your concerns, and that require medical decision making. So this is nothing administrative. So, any administrative service like getting appointments or those types of things, none of those things should be included in what they charge you for or have the option to charge you for. And also it says at the onset of the COVID pandemic, they saw a massive increase in the amount of secure messaging that patients were sending to their physicians, on the order of 150% increase. And so that was what prompted them to kind of do the study. But they did say that there were limitations to their study. And I think this would be really, really interesting for someone to probably do a even further, deeper dive into a study. It said the lack of assessment of email profitability. So they don't necessarily know like what the bottom line looks like as at the time of the study. The inability to assess what proportion of patient-initiated message threads require medical decision-making. I think that's key. And at least 5 minutes of time to meet e-visit billing criteria. And I guess for me, I get that it's listed as online digital, but that 5-minute phone, is it really, or that email, is it really an e-visit? I don't know. I mean, I feel like, I don't know. But anyway, they also said clinician satisfaction with e-visit billing and whether any reduction in messaging resulted in worse patient outcomes. So those are some of the things that they that were limited in the particular study they did. They also said future research should investigate overall costs under different payment models and the effect of billing for messages on outcomes, health equity, and patient and clinician satisfaction. For those of you on LinkedIn, for those of you on YouTube, in the description notes, all of the articles are listed there, so you can go and take a look at that. Mr. Jesse, did you have anything you wanted to add?
I had to unmute myself. I have a question. If there are CPT codes that allow for online evaluation, why are providers charging for emails, or is this part of the charge for the emails? They're using that code to bill a customer.
So ask it again, I'm sorry.
If they have CPT codes available for providers to use for online evaluation for as low as 5 minutes, the charge that providers are charging customers for emails, is that part of that fee or is that in addition?
That's technically part of, so that 5 minute, the emails are part of what they're calling online digital evaluation and management services. So if they email you, if they direct message you, any of that, that's all lumped into that. I read an article recently that, I think I talked about it. I talked about it somewhere. I talk all kinds of stuff. I talked about it somewhere about the AMA making some adjustments and changes again to CPT to add a telehealth E&M visit. So then that will be a separate entity in and of itself, away from your traditional, I guess, face-to-face E&M. But yeah, this will be lumped into that.
Okay.
Wait a minute.
To add to, when I was doing my little, mini research on it, the providers that I normally work for and the company I used to work for, the providers always they blocked out time in their schedule every day just to answer questions and phone calls and whatnot. And they never, say, okay, well, 5 minutes, I'm going to charge this patient. So to me, it's all about time management. Just, I would say, I was telling from my providers, like, block out some time in your schedule, at least an hour or so, to answer phone calls or look at the portal and, answer questions from your portal or, an email, because, we do have, they do have some patients that do emails, but I know for like the older generation, they might not be so technically, savvy, with the internet. So they usually just, call. Because when I used to work for a psychiatry behavioral specialist office, we had a lot of older clients who would call, if they had some issues with their medication or they wanted to get a refill and whatnot. And the providers always set aside at least an hour of their time to do that. So, like you said, Clarice, it's like a nickel and dime grab.
Yeah, I really feel like that's what's happening, and it's unfortunate because sometimes they're reaching out for, especially if copays are involved. I think that was the other piece that I was reading, the possibility of having to pay a copay in addition to being billed for the email. I'm like, wait a minute, time out. I think you at that point they may be doing way too much. There's another article, and I'll share this with you guys. It's also in the YouTube video description. It talked about how the number of MyChart messages drops after hospitals start billing for them. And so I don't know if the billing is a way for them to get them to stop doing the messages and having them to answer. But what I found really interesting for this particular, it was actually the comments, because they were going in. So this one comment. So Carolyn says, we are surprised why. Anyone could have noted this would be the outcome. People are counting pennies just to survive. Do I MyChart my physician and get charged, or do I eat or pay for meds or pay the rent? I know physicians are getting their reimbursements reduced, but charging patients for MyChart questions is not the way to recoup those funds. It is a patient safety avenue. How many adverse events or unneeded ED visits have been prevented because people felt free to reach out with a quick question via MyChart? So then Lon says, I disagree. A fee for taking a phone call or email would incentivize doctors to interact with their patients without the patient having to see the doctor in person. As it is, doctors resist phone calls or emails because there is no reimbursement for it, and that time could have been spent seeing another patient in their office for which there is reimbursement. Further, if so many people are counting pennies, we could make the bill for phone calls / emails lower. I believe they would rather pay a $25 copay to speak with their doctor on the phone or by email to get something like a medication refill than to pay a $50 copay, take a day off for work, travel to the office, sit and wait, et cetera, et cetera. I just recently had a conversation with several friends who said the thing they hate most about healthcare is having to see their doctor in person for med refills. But it's the only way most doctors have of getting reimbursed for managing that patient. It's silly that doctors are not only professionals that only get paid if you meet them at their office. Think back to the last time you interacted with an attorney or lawyer by phone or email. I'm sure they billed you their full hourly fee, which makes sense. Their expertise is equally valuable, however delivered. Would you have preferred your attorney require you to make an appointment and waste your time, money meeting them at their office for every trivial question you have? If your goal is to increase patient safety by increasing physician contact, perhaps reimburse physicians to incentivize them to make that contact as easy and cheap for the patient as possible. Making it free is what creates the barrier. She goes on to, Carolyn says, well, it might incentivize the providers, but doesn't serve the purpose. If people reduce or stop using the modality, which is what is happening. And then he says, if a patient can't afford a reduced phone call fee, they certainly can't afford an office visit. So these patients, doctors should just care for them over the phone or email for free. Actually, it's not free. It's a cost to the doctor because they cannot see other paying patients during the time they're on the phone. This is the equivalent of a physician paying the patient for the patient's convenience. And those paying patients have a harder time getting an appointment with me. This is when he dropped the bomb that he's a provider. If I must spend lots of time on the phone or email. Furthermore, caring for patients over the phone, email is even higher risk than seeing them in the office. So an argument could be made for charging a higher fee for the patient's convenience / my risk. Everyone deserves to be paid for their time, and charging a reduced fee for the same amount of time in a higher risk activity is more than fair. Spending time for riskier patient care without reimbursement while incurring the opportunity cost of seeing other paying patients is unfair. And it leads to abuse of the system, which necessitates requiring something from the patient for the call or email. The system is set up such that doctors only get paid for seeing patients in person. Therefore, any phone calls or emails should be seen for what they are: compassionate sacrifice on the part of the doctor, not something a doctor owes anyone for free. And as the article states, 98% of the time, the doctors compassionately stuck their necks out and inconvenienced themselves and other patients at their own cost. But the better plan is just to reimburse physicians for their patient care time, whether in person, on the phone, by telehealth, which, by the way, is not free, but is almost identical to a phone call, or by email. And she says, I'm sorry you feel this way, but we will agree to disagree. Many patients who can't afford an office visit use my charts for queries. Now, the first thing that came to my mind when I read this particular back and forth discourse was, somebody is not in tune with their patient population. Let me just say that. I feel like they did just throw all the work regarding health equity, throw all the work regarding social determinants of health, throw all the work just out of the window regarding understanding your patient population and mix. I feel like clearly there is a lack of cultural competence with this particular provider and some of the things that he said. And maybe the providers or the patients that he sees, maybe they don't have the same situation going on, but clearly we all know there's a huge population that, yeah, it's easier for me to ask you a question. And I think she made a very great point. It's easier for me to get a quick phone call than for me to go and to the emergency room for something that could have been easily remedied. This was just, it was way too much. But go ahead. Anybody want to jump in?
Well, I just want to say, he lost me at compassionate sacrifice.
Ma'am, sir. Sir. But the thing is, you got to remember, for a lot of and I don't know whether he's a private practice, and I know there are some differences between a provider who has their own private practice versus one who is employed by a health system. Those employed by a health system, have a little, I guess, a cushion because they're getting a salary. They're not necessarily relying on the reimbursements from their patients. What providers, I think, on both ends of the spectrum need to understand is, one, that patient is your customer. That's their bread. No patients, no money, no salary, no nothing. And so let's be clear about the importance of patient satisfaction, whether that be convenience or not. Molly, I love the point that you made about taking that time and time management to kind of schedule off a day or a couple hours, per day, to kind of review those messages. Maybe even hiring staff to monitor that. Maybe there's another option to have somebody kind of monitor the emails to determine, are these emails that someone else can potentially reach out for, or is this something that, you know, to triage those, if you will. This needs to go to the doctor. This needs to be managed. They need to handle this versus, oh yeah, you know, a qualified person can take a look at that chart and say, oh yeah, this, and the other. Here you go, and do that. I mean, I don't know.
They do that already.
But clearly, somebody feels like they're not, and they're being bombarded with all of these messages that they can't handle. And so now they need to pay for them. And don't get me wrong, I understand time is money. Trust me, I understand time is money because it's where the money resides. However, if I think we have to find a happy medium here, I guess.
Do you want to weigh in, Molly? Because I got more to say.
I got my tea ready because I knew you was coming for it. I got double bag today, double bag.
Yeah, I was going to weigh in real quick. I was weigh in really quick and then let Jesse go. But you're correct, Jesse. They most doctor's offices, they do have someone in place to look at emails or do phone calls. I know when I used to work for an ear, nose, and throat specialist as well, then his main nurse was doing like the callbacks with the the messages and also checking the portal. She would actually take about an hour or so out of her day to just go to her desk and just answer questions or do phone callbacks from patients and whatnot. And then if it was something that it was directly for the provider, then at the end of the day, she would go to the provider and say, hey, I wasn't able to call this patient back because of X, Y, and Z. And then he would speak with her, more with that regarding that patient, and then she would call the patient back and give that patient an answer. But yeah, to me, it's kind of like laziness a little bit on the lazy side, because most doctor's offices, they do have someone, whether it's a scheduler or supervisor or an admin or the nurse.
So that's even more of a read. Go ahead, Mr. Jesse.
What keeps circling around and what has become the elephant in the room is nobody wants to hold providers accountable.
Come on now.
Nobody wants to ever tell them, or even CMS, that's your job. And until that happens, this is going to continue to run rampant. And this is the same, this same issue shows up in all kinds of issues all across the healthcare spectrum. It all comes down to providers not doing their job or wanting to not do their job. Because, I work in inpatient, and why is fatigue the only thing associated? Why is that label only attached to providers? Like no other job has fatigue
or burnout or
exactly. Because they tell us all the time, well, you want to make sure that you only query when necessary because you don't want to, because providers get query fatigue. So see, I'm very good with rules. If you only want to do a certain thing, if it's only going to affect reimbursement, then to heck with everything else. If it's not going to affect the money, don't ask about it. So what? She has a stage 2 pressure also that's going to get reinfected in 2 weeks and she'll be back. Who cares? It's not going to affect the DRG. Let her go. Why even bother? But there's something called quality.
Mm-hmm.
That you have to, there's a standard in American healthcare that you have to meet. And I just think that, I'm just going to freaking say it.
Say
it! As long as healthcare is run by white men and white women, it will never change. White women are never going to challenge white men, ever. And that's the real. Black women will give black men hell all day long.
Ask my husband. No, I'm kidding. Oh,
They will contort themselves to work around and to accommodate. Sir, you are a petulant child. Do your job or go work at Home Depot.
because they need people
That's
too.
it.
They need people too. So I also had a conversation with a friend of mine, and so this makes me understand the whole concierge medical service thing too, because in those instances you're paying like a monthly fee for the provider's time. I mean, you pay a monthly fee for what was it? To get your appointment or to be on a list to get the first available appointment or earlier appointments or all of that. But then you also included in that fee was the additional telephone calls, emails, and all of the things that come with that. So I think this is their way to kind of even step into that realm on a sneak, because they're paying. It's like a la carte. Everything is a la carte now. Like, why can't I just go to my doctor? Oh, by the way, after I saw the physician or the nurse practitioner, or whichever provider, I got my information. I read it over. Oh, I had a quick question. La 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 la. Just really? Now I got to pay a whole other copay just to get an answer for that. Maybe that may result in changing medication, may result in a whole other appointment. I mean, it's like it's a snowfall. It's ridiculous. It's too much. It's too much. And all I can think about is my elderly patients. Like, oh my God. Like, and to that provider's, his thoughts. Clearly, you don't have any elderly patients. Maybe you don't have any elderly patients in low socioeconomic areas, because it is a true thing that happens with, do I pay this money to go see this doctor? Because they still have to come out of pocket, even if they're on Medicaid. So sometimes there is a copay. They still got to come out of pocket. Do I pay this copay? Do I eat? Do I get the medicine? Do I pay my rent? Do I pay for the electric in order to, or the phone bill in order to be able to call? I mean, it's so many other things that they have. And this is just a pool of money I have. There's no other money coming in here. It's just this. They're on a very fixed income. And so now you tap in and dip it into that, especially if they are, savvy enough to go in and initiate these conversations. It's crazy. It's crazy. Craziness.
But the thing is, they already know. They know this. And like when you were talking about the senior clients, everybody knows that the baby boomers are the largest population currently, and they're going to need care for the long term. You have some baby boomers who cannot even retire because they don't have enough money. So the ones who are fortunate enough to retire,
they at Home Depot too.
You're going to nickel and dime them, and it's just my frustration is every issue in this country comes down to race, gender, or class, and nobody ever wants to talk about it, ever, ever, ever.
It's the largest elephant in the room.
And everything will come down to either one of those three things. Every issue.
And I agree with you 100%. Like you said, to Clarice, they're on a fixed income, so they have to manage and budget out their money on a monthly basis. So, and then too, going back to the insurance, I want to say, this is just my guesstimation. I want to say maybe in my state, I want to say about 80% Michiganders are on Medicaid, and you can't charge for Medicaid. So I figure, and Medicaid has that set fee schedule as well. So a lot of some providers, I won't say a lot, but some providers, especially if they have their own practice and they're not contracted with a hospital, they will not accept Medicaid because of the, the set fee schedule. They, it's money. So they figure, okay, well, let me charge my commercial patients. Let me, see if I can get a little bit, what was my mom used to say? Was a saying about squeezing the turnip dry or something till it bleeds or something. Let me see what I can get out of my commercial patients, and what monies or revenue I can get out of them. Because God forbid, my Medicaid patients, I'm not able to bill because that would be in violation. So it's pretty sad. And like you said, Jesse, like compassion. I don't see any compassion for providers who want to do this, to their patient, especially if they have elderly. Mostly of their clientele is, elderly patients.
But this is also why providers are around here smearing nurse practitioners, because that's the Achilles heel.
Come on now.
That's going to be the thing to switch all of this up. When all of these states go over to full practice authority, doctors have lost. It's the end of the MD. And they know it. Because nurses who go on to become nurse practitioners have an entirely different mindset towards patients and patient care.
That's right.
Completely. And they know that they're going to lose control.
That's a lot.
But that's the answer, though.
It is because they paint the picture that the supply and demand. So you don't have enough providers, and so you got to wait months and months and months to get in to see a provider. So don't wait. Initiate this email or initiate this call to a provider to get some questions answered, or go to the ED. And you don't want to wait in the ED. You don't want. I mean, it's not mind boggling. It's money. Where the money reside. Where the money reside. It's all about the money, the dollar bill, and that's unfortunate. That's unfortunate, especially as to your point, Mr. Jesse, about the baby boomers being the largest, and they are mostly the ones with the greater need because they have more chronic conditions that need to be managed. And yeah, they saw a cash cow, and let's go for it. And then and so I'm trying to feel a little bit for the provider, only in that I know, and I'm only speaking to the employed provider. I guess the other a non-employed provider probably feels the same, but it's their job has become production. It's production. You gotta tick them in, tick them out, tick them in, tick them out.
But
go ahead.
But whose fault is that?
I totally agree. I totally agree. And to Molly's point, it's about time management. I remember, and it's been some years, but I remember like going to a hair salon and they would like double book, triple book on top of books just to make whatever, and staggering. And I think in healthcare, a lot of that happens and a lot of that occurs. However, one, to me, to the patient's detriment, because really technically I only got 15 minutes to sit here and talk to you, even though the patient may come in and they don't want to just talk to you about the one issue. They got 6 issues, and I got your undivided attention. I need to talk to you about my 6 issues. I need you to address my 6 issues. But you steady trying to push me out. Okay, Miss Jones. All right, Miss Jones. Well, okay, Miss Jones. Well, for that, let's talk about that at the next appointment. So again, cha-ching, and creating another revenue stream, if you will, because now you got to come back. Well, but I'm right here. I'm talking to you. And they go steady try to talk to you until you actually just get on up and walk out the door. You get on up and walk out the door. So I'm like, really, at what point? It needs to be just a whole overhaul, and people really need to think about their customer. It needs to be about customer satisfaction, what the customer outcomes, thinking all about the types of customers that you serve and the health equity of the customers that you serve. All of those things need to be brought to the attention in all of these payment models for not only the providers, but even because health insurance, they got a bag in here too. They got a piece too. We ain't uncovered their piece, but they got a piece in this as well. All of these things just need to come to the forefront, and all these folks need to come to the table with the customer in mind.
But how can you have the customer in mind when you're making compassionate sacrifices?
Who, sir? Sir.
It's just, when you were talking about, because I could just see all this is becoming just more and more crazy as time goes on, and yet still this is not a new issue. It's really not, because I remember I had an aunt who she passed a long time ago. She had to go she was seeing a cardiologist. She wanted me to take her to her appointment. I go, we wait 2 hours for this man for her appointment. We go in the room and he's trying to rush. And I'm like, she asked questions. He walked out the room. Oh, but see, he ain't know.
He ain't know who he was dealing with.
I went right behind him. I said, excuse me. He ignored me, went in the other patient room and closed the door. I opened the door. I said, my aunt has questions. You either gonna answer them right here or you're gonna bring your ass out in the hallway and talk to her.
It was a whole situation. I bet you everything stopped like,
It sure did.
You know what? I usually go to my mom's doctor's appointments with her as well, because I always I have my little notebook with me, and I write my questions down, because sometimes she's forgetful, and then she'll get home like, oh, I forgot to ask. So I usually go. So I try to make it to almost all her doctor's appointments, because her time, my time, her time, and the doctor's time is valuable. So if we're coming in here to see the doctor and address issues, I want all the questions answered. So yeah, that's what I do. I go with her, and because I'm in healthcare, I already know. I used to work front desk. I know all about that. So when I go to her appointments with her, they know me by first name. They probably know what kind of car I drive, my license plate number too. That's how many times I go with her. So it's always good to go, to the doctor, with an elderly loved one, because let's be honest, some providers or doctors, they do not, some of them don't have good bedside manner. They don't at all. So it's sad to say, that they feel like of course they're getting paid for what they do, but where is the real compassion, instead of looking towards the money all the time, So yeah, I'm kind of on the fence about this charging, for patients for emails. I say go into the more 10-figure, 8-figure, 9-figure area.
Specialty. Go on to cardiology if you want to make some more money. Go to a higher specialty. Go on to dermatology. Go on somewhere else. You chose primary care, or you chose family medicine, or you chose pediatrics. You chose these areas, and you chose them for a reason. And you knew the patient makeup. You knew what it was. You knew you weren't gonna make that cardiology money. You knew you weren't gonna make that money there, but don't try to make up for it through the patient. Come on, y'all. My compliance hat always comes on, and I'm like, just because you can do it, should you do it? No, not in every instance. No, I'm just, and you all know I'm a primary caregiver for my mom, so I'm right there with them too. And then most of them already know where I come from and what I do, so it's real. Because I'm like, wait a minute, I know. I done watched your charges. I done watched how you build her. Some of the things I agree with, and if I don't agree with, we having another conversation. Like, this didn't happen, and this didn't happen, and you didn't do this, and we didn't talk about that. So let's revisit. But you want to bill that or charge for that the highest level E&M without doing any of the work related to that. Let's talk about that. But again, that comes back to that administrative documentation burden that you have to just put the information down in the chart. It's like, if things were, I think I would have I would feel a little better about providers if, and not all providers are in this boat. Let me just say that, because I have providers who are my friends. So not all of providers are in this boat or do that. But if if the documentation was there, if the effort was there for the documentation versus, just copy, cut, and pasting, that's a whole other conversation. If you really could just glean the whole patient perspective and the patient story from the clear and concise documentation from those providers on a encounter by encounter basis, I would feel a little better. But if you are not wanting to even do the bare minimum of your job, which is documenting the encounter, but now complaining that it's too much, and now you want to call me, and now you want to get some additional advice via email, and now you want to do this and that and the third. Come on.
But see, it all comes down to documentation for me.
All of it.
Because they want to nickel and dime with the little things because they getting denied for the big things.
Because they're not documenting.
Exactly.
You better say it.
Exactly. And also to your point, Clarice, like we really it's amazing that you were talking about how we can't leave insurance out, and you really can't, because doctors, they forget the history. 30 years ago, doctors were robbing insurance companies blind. Now the insurance companies have put their foot on these doctors' necks, and now you want payment? No, they like eat the cake anime.
All of it.
And I forgot to add too, that what if the patient has a high deductible on their plan?
Right. So they're paying the full cost of that. There is no copay. Right. It's the full cost of whatever it is.
Mm-hmm.
They're not thinking about the patient at all. And let me just say, at least in the one particular article, they were only doing 2% of the actual patient-initiated emails that were coming through, because it was kind of a trial. So they were just going through and saying, 2%. But eventually that 2% is going to be 50%, and so on and so forth at the rate that they're trying to go. So I don't know if they're trying to push this message to keep folks from initiating the emails, or having these email interactions through MyChart or whatever electronic health portal they have, or is it the other way where we want to begin to increase these types of interaction, but no, with the increase, a fee will come. I don't know exactly which way they're trying to push it.
And it almost seems like they're like, and I discussed this before in my room, that they're trying to force the patient, like, I want you to come in and see me, but I'm going to charge you. If you email me, you're going to get charged. So maybe that's going to force that patient to come right into the office and pay that copay to see the doctor, versus sending an email with something very minor. So yeah, it's like they're putting the patient back up against the wall.
Mm-hmm.
And this is what you better do. And if you don't, shame on you. I'm going to charge you for an email.
Mm-hmm. It's crazy. And to the point about the waiting in line and the wait. Oh my God. Some of that is off ridiculous. Manage your schedule better, sir and ma'am. How about that?
But the reason why they have to, like the salon example you use, is because it's all about money. How many people can I pack in a day? How many people can I zip? And you also have to know your clientele. Like there are some folks that will ask you, you could be there an hour, but if they require that amount of care, look, there's an E&M code that will handle that.
That's right. As long as your documentation supports it. Let's do that.
Right. So, and I get it. I'm not even saying that healthcare reimbursement should not improve. And we also have to be very, very clear that there are billions upon billions of dollars circulating in healthcare every day in this country.
Mhm.
So I don't know how much of it is truly a lack of money, or is people don't know how to document to maximize their money. And I would think that it's more the latter, because I just know, like, the documentation I've seen for years, since I mean, I've been in coding now almost going on 10 years. It's terrible. And more recently, it's not getting any better. That's the thing. I don't see an improvement. I actually see a regression,
Yeah.
because the whole, like, people don't even realize, like, copying and pasting is really fraud. Because how can we really tell that you really did that level of service when every note you have has the exact same thing?
Right.
Did you really assess the patient at all?
And how can you clearly demonstrate you put any sort of medical decision making into that particular encounter if you're just copying and pasting from whatever happened before? I think, and I went to a session at OHEMA that talked about the impacts of the new E&M code changes. And of course, the jury is still out, and there still needs to be some additional research to happen. And they were kind of focusing on inpatient more than outpatient, but I feel like we've had a year or so more in on the physician side and outpatient side. So there should be some research or some data out there for that. But again, I think, and to your point, having concise documentation, there is a way to document the services that you have that doesn't require all of this note bloat. It doesn't require all of this additional stuff. You don't have to document all that stuff. You just have to make sure you're documenting appropriately what happened, how that patient presented, what your medical decision making is, and make sure you hit all of the conditions or diagnoses that the patient is presenting with. There's a concise way to do that, and it has been for years. But unfortunately, there's some providers that, one, they have no idea. They're not paying attention to all of the education and information that's out there to them, and they're trying to follow. Oh my God, well, my colleague does this, that, and the third, and they put all of this in there. So I think I got to do all of that. And so I'm putting all of this in the third on my stuff. And another colleague says, the other said, well, oh, wait a minute. No, don't forget to add this. So now you got a 4-page note for a patient that you may have spent 15 minutes in. It's ridiculous if you just learn how to properly document for the encounter at that day that you're seeing with that patient. I think some of their administrative burden, fatigue would go away, as well as ours. Go ahead, Mr. Jesse.
And I agree. And stay in your lane.
Woo!
If you are a cardiologist, you have no business diagnosing sepsis. None. That is for infectious disease or the attending. You just stick to the valves and the vessels. You clear that person from a cardiac standpoint. If they have congestive heart failure, that's your lane all day. But why are you documenting anything about sepsis?
Because then they're trying to add to it. So if the more diagnoses I add, the more information I put, the higher the E&M code I could. No, every code, you should not be trying to maximize every single. Sometimes it's gonna be a low level service. Just it's gonna be that low service. Sometimes it's gonna balance out. That's why you have the bill. It should balance out. Everyone shouldn't always be at the high level. Everyone shouldn't always be at the low level. Depending on your specialty, it may be skewed higher, which is acceptable. You would expect that, if you were in a specialist and you're seeing sicker patients, yeah, it's gonna be skewed higher. But sometimes you're gonna have to take one for the team. It is okay. It's okay.
I had this just happened yesterday. I had a patient whose case I was doing, had a total abdominal hysterectomy laparoscopically, and came to the hospital a couple of days later with she was diagnosed with a small bowel obstruction. 3 different specialties diagnosed different reasons for the obstruction. Patient was discharged. Do you think in the discharge summary, the attending clearly documented what the reason was? No.
Mm.
So I had to copy all 3 notes and in my query and come up with how they treated it. And I had to craft questions so that I could get the diagnosis I needed and the coder needed so we can code the case and get it done. It's ridiculous.
It's ridiculous. Beyond ridiculous.
But there is not enough. If I have to say one thing in support of doctors, there is not enough. And on any stretch, by any stretch, there's not enough provider education. And provider education stops needing to be hand-holding, because when I get evaluations, I'm told this is your productivity, this is the standard, you either met it or you didn't. And if you don't, as a coder, they will put you behind on a PIP in a minute. And that needs to be the same way for these providers. Stop with the hand holding. It is what it is.
I agree. Particularly those who are employed, because you are an employee and you should be treated as such. And you should be treated as such.
I don't know what it is like about them going to some type of webinar or a refresher course. I don't know. It seems like some of these providers have so many excuses not to go to a webinar or a course just to get refreshed, a little bit educated on certain things, updates and everything like that. They just seem like that's just beneath them. Like, oh, I'm a doctor. I have patients. I don't have time I've done my schooling. It's crazy.
But you know what? There is something to be said for that, because that's a very good point. Because we had to attend this webinar on respiratory failure, which was interesting, but the presenter was just as dry as it was like, Sarah, we got places to go. We got things to do.
I've been to some dry webinars before.
I actually clicked off. I'm like, I can't do this. I'd rather go back to work. No. So I really think, truth, real talk, healthcare needs to be revamped, period. And education is one of the things that needs to be revamped. Yeah. And I think that they need to really bring educators into provider education, into nursing education. No longer can we rely on, this 30-year nurse in the game to be training people. Yeah. No, we need new methodologies. There's now with technology, people need to be engaged. You need interaction.
People learn differently, and so you need to meet the different types of learning that people have. All of those things need to be incorporated. I agree. There should be some education.
So you can no longer say, "Well, I did the seminar, we addressed blah." No.
Yeah, that shouldn't be. It shouldn't be a check off on your objective list. No, not at all. You are absolutely correct.
Education needs to be way more engaging than what it is, and I think that would improve compliance and also engagement.
And I think providers need to also understand, even though they are, I think to some respect, they do understand that they are in a field which requires lifelong learning as well, because of the different things that happen, different diagnoses that come out, different procedures that come out, depending on the healthcare or specialty that they're in. But included in that, to your point, should also be a component related to the documentation or the expectation of the documentation related to that. I think that's where it kind of falls off. Like, yes, you're learning about this new disease. Yes, you're learning about the treatment and the protocols for this particular condition. But what about documenting that? And what about, making sure that the documentation supports, what you did, making sure the documentation supports the diagnosis code and it's as specific as it needs to be. I think all of those factors need to be brought into. So maybe it's a side by side, you have your clinical people telling you, hey, these are the new protocols, these are the new things, the new standards, these are the new things that we're doing. And then on the side, you have somebody that, is savvy in providing the additional education related to the documentation and the needs of the provider for that. So maybe it's a tag team type of thing that probably needs to happen. I don't know. But at some point, that whole documentation piece is just lacking and they're not getting the additional information that they need in order to do that. And I think we got 3 folks, at least right here in the room, that can help anybody else. So if you reach out, if you need some assistance, reach out. We got you if you are a provider.
That's like, I code metabolic acidosis at least a couple times a week. Effective April 1st, there are going to be 4 additional metabolic acidosis codes that's going to break it down. Is it acute? Is it chronic? But there has been no mention of it. And you don't educate after April 1st, you educate before April 1st.
Don't get me started with that. That's a whole pet peeve for me. I'm like, yeah, when I mentioned it when they were changing the E&M for inpatient, I'm like, it's crickets out here in these streets. Yeah, what? Not every provider provides outpatient services. Sometimes you do have folks that are just in the hospital. They have no idea what they're about to get into. They were blindsided oftentimes. You have your internists, you have your hospitalists, you have those who just strictly work in the hospital. And now you got all these new guidelines and now you want them to know how to do it right now when they're trying to see. It was a mess. It was a mess. It was a whole mess. I don't know. Well, this was great. Molly, I appreciate you bringing the topic. That was, Now, Miss Molly, I know you have an ebook or something that you have put out there. So the floor is yours. Let folks know what you got going on.
Okay. Yes, I do have an ebook and I created it for the medical office, like even if it's a dentistry or GYN or just a regular internal medicine. It's tips on how to, gain revenue within the practice. It is for providers. It is for like this, admins in the practice. Also it applies to front desk workers. Also applies to the billers, the coders, and the person who does the transcriptions if they even have transcription person anymore. And it is on Amazon.
Okay, I tried to place it in the chat or thing, so it broke up on one of them, but yeah.
I see it. Thank you.
You're welcome.
Ways to increase revenue in your medical practice is about 6 tips on how to increase revenue within your medical practice. So good, easy tips. You can follow them from demographics to insurance and to just giving a couple of things, throwing things out there, and payment arrangements for your clients or patients as well. So it's a good book. It's on Amazon. Check it out. It is an ebook, so you can download it to your Kindle.
Cool. Well, thank you. I love it. Yes. So this was real good. Y'all had my pressure up. Let me breathe now. Come down. Woo, boy, it never ceases to amaze me when we have these conversations about providers, documentation, all the things. To be like, woo, it takes a whole different turn.
You're passionate.
That's what it is.
We're passionate and doctors are compassionate. See, that's the disconnect.
You ain't gonna let that one go, are you?
I swear. You're gonna be at Clubhouse in December and be talking about this compassionate sacrifice.
That's gonna be our new word. We got compassion, sacrifice. We got gatekeepers. We got it all. I love it. Nickel and dime. We got it all. All the things. I told you we talk all the things in this room. All the things. something that hit us, and we'd be like, but wait a minute, hold up. What about this and that and the third? So like I said, all the links will be definitely in the YouTube description. Molly, I think I added your book. If I didn't, I will make sure I will add your link to get your book as well. Your ebook.
I see it right there.
Okay. Okay. Cool.
Yeah. I appreciate it. Thank you so much.
You're
I had so much
welcome.
fun.
This was great. I
It
did
was a great
too.
time.
So see how easy it is to come on and be a guest with us. Don't be afraid. If you got something that you want to like, I happened to see her see the information in her room, and I said, well, wait a minute, let me, ma'am, you talking over there, come on over here and talk over here. See, collaboration, we could collaborate. So, you know, there's information that she has that she could share, and information that I have that, you know, we can share. It's a whole collaboration, and I love it. I love that we are here for. Every Saturday morning, 9 a.m. Eastern Standard Time. So again, thank you all again for joining the Saturday morning tea. Let me ask, you know, I'm going to ask, was the tea spilled today?
It was spilled, mopped up, and wrung out and spilled again.
And it was hot. I got burned. Yeah. You see, I almost choked one time. Like, wait a minute. Oh, it was piping hot tea. I love it. So if this information was valuable for you, help us share this message with others by liking the video, sharing the video, and subscribing to the channel. You can also, the Professional Reimbursement Network is our channel. You can also check out the Coding Nurse channel on YouTube. And Miss Molly, I think you are the healthcare business consultant on YouTube.
I think you're muted, Molly.
You're still muted. You're muted on. Yeah.
I'm sorry. It's at Healthcare Business. That's my handle for YouTube.
Okay, at Healthcare Business. So check everybody out. You all know I got a whole goal of 10 to 20,000 people. 10,000 with a stretch goal of 20,000 subscribers for the year. So tell a friend to tell a friend, make a friend and tell a friend, and have them subscribe to the channel. And like I said, you can also check out the Coding Nurse channel as well on YouTube. You know, Mr. Jesse is always dropping those gems, so check out his channel as well. Last but certainly not least, to my Clubhouse folks, click on the greenhouse to join in the fun in our club, and you will get notified of our live broadcast that happens every Saturday morning at 9 a.m. Eastern Standard Time. I haven't played around in Clubhouse to understand like the houses and the other things that's going on. I need to do that, but we'll get there. We'll get there.
If you have questions, please let me know, because we were just discussing that the other day about the house.
Yes, I'm like, well, wait a minute. I see all of this newfangled stuff. Wait a minute. Let's see how I can play. Where else can I play? So again, this has been a great session, and thank you, Molly, for joining us. We appreciate you. Yeah. And of course, if there's anything that we can do, or if there's any other time that you want to come and join us, by all means, the floor is yours. You're welcome. So thanks again, everybody, for joining us. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, thanks so much for watching, and take care.
All right, can we chat?
Yes, we can. Okay. Always. Wrong thing. Hold up.